Okay, hello and welcome to today's webinar, Rural Texas Strong and Texas A&M. Thank you for joining us. We are recording this webinar and we will share a copy of the slides and the recording with all registrants following the presentation. I am Cassidy Avila with the Texas A&M Rural and Community Health Institute, and it is my pleasure to extend a warm welcome to you and introduce the agenda for our time together. If we can advance to the next slide. Perfect. Dr. Kia Parsi, the Executive Director for the Texas A&M Rural and Community Health Institute, will begin by providing us with an introduction on Rural Texas Strong. He will be followed by Victoria Grady, the Director of Provider Finance in the Chief Financial Officer Division of the Texas Health and Human Services Commission. And Victoria will summarize the 6 Rural Texas Strong initiatives, and we will then pause for questions. There will be about 3 to 4 pauses for Q&A during the presentation, so I encourage you to drop your questions into the chat as they come up. You can also drop your name into the chat if you would like to be unmuted during Q&A and ask your question personally. That's fine as well. Next on the agenda today will be John Henderson, the President and CEO of the Texas Organization of Rural and Community Hospitals, or TORCH. He will share his perspective on Rural Texas Strong, followed by another pause for questions. And then to wrap us up, Dr. Parsi will provide additional details on the Rural Texas Strong metrics and eligibility, as well as the role of the Texas A&M University System Hub created by the Rural and Community Health Institute. So now I will turn it over to you, Dr. Parsi.
Thank you, Cassidy. I have to say I'm very excited to be on this webinar and to discuss with all of the Texas A&M system members that are present today about this opportunity. This is probably the largest fund focus on rural health that I have experienced in my lifetime. And so it's very exciting. And we have 5 years in a journey that we can all pursue together to improve rural health care. I'm going to start by just discussing, first of all, my personal experience. Spent about 20 years as a rural family physician, followed by 7 years as an executive for a hospital system in the Brazos Valley as a chief medical officer and CEO. But in 2022, in November, I became executive director of the Texas A&M Rural and Community Health Institute. So why are we here? And how did this funding get created? And I think the history will help explain the focus and the purpose of Rural Texas Strong. When the federal government passed the One Big Beautiful Bill in the summer of 2025, there were significant cuts in funding to Medicaid and marketplace insurance, Obamacare plans. And these cuts potentially disproportionately affected rural hospitals and clinics throughout the country. And let me give you a couple main examples as to why that is disproportionate in the effects to rural communities. When I was CEO here in the Brazos Valley, we looked at our payer mixes to different communities. And in the College Station area, the Medicaid population was about 8%. We were treating about 8% of our patients that had Medicaid as a beneficiary. But looking in the surrounding rural communities, Madisonville, Burleson, and in Grimes County, we had 20 to 25% Medicaid population that we were treating. And this is consistent in Texas and rural communities throughout the country. Higher percentage of their patients that they're treating have Medicaid. So funding for Medicaid, if it's decreased, will disproportionately affect rural communities. Another example as to why this is disproportionate to rural healthcare institutions is related to operating margins. Many rural, looking at urban operating margins for hospitals in suburban and urban areas, often their operation margins are in the positive in the double digits, 10, 12, 15%. A 2% drop in margins is difficult, but manageable. Our institute throughout Texas works with rural hospitals that are at barely break even. If they have positive margins, they're in the low single digits. A 1, 2, or 3% drop in operating margins goes from breaking even to being in a deficit. And that's why this concern for the decrease in funding for Medicaid and marketplace insurance disproportionately affecting rural communities was a focus for many in Congress. And that's where the Rural Transformation Program was created. a program funded through CMS, a federal program, $50 billion over 5 years, and will be managed by CMS with each state applying for funding. Now, Tori will talk a little bit more about how this was implemented, but there was a very short period of time for each of the states to create their own applications. And for Texas, we're talking in a matter of weeks. So $1 billion funding opportunity. The governor of Texas, Abbott, placed this responsibility in the hands of HHSC. And Victoria Grady and her team, with a consultant who was highly experienced and is presenting today, were able to create the Rural Texas Strong program, a $1 billion proposal that then was given to CMS, and then CMS was able to make a determination on how much funding for each state. Texas got $1.4 billion. That is the largest allocation to any state. That's the good news. The bad news is we also have one of the largest populations of rural individuals. We have about 4 million rural participants, members in the state of Texas. So if you look at a population base, we are at the lowest level of funding. But we're not complaining. We got $1.4 billion, which is a large amount of money. And remember, the focus here was to try to prevent the impact of Medicaid cuts to rural hospitals and clinics and try to prevent closure. And as we look into Rural Texas Strong, that sort of explains how the funding is being determined. Another thing I'd like to mention to you all is CMS has the opportunity to reevaluate funding every year. So the $1.4 billion for Texas over 5 years is a projection. Depending upon the performance of Texas and other states, each state could get more or less than the projected funding, depending upon the performance. So performance is very important. Now, as academic institutions, I know one of the questions that many of you all are asking is, how much of this funding would academic institutions be eligible for? Now, don't get too scared with this last slide because we're going to discuss it further. In general, and this is from the Rural Texas Strong document, in general, Rural Texas Strong funds will not be expended on programs or services administered by state agencies, institutions of higher education. This is to ensure that funds are expended at the local community level to the greatest extent possible. So if you look back as to the reason for the funding, to help with the potential cuts to Medicaid, prevent closures of rural hospitals and clinics, there was a specific intent to make sure that the funds are given at the local level to help these rural institutions not only transform, but stay viable. I also want to mention that research is not a focus of Rural Texas Strong funding. So you may think this is a short presentation for those of you in academic institutions that you may not have an opportunity to participate, but you do. Because these funds, many of them will be distributed at the local level, many rural hospitals and clinics will need partners. And as a system, we have resources, we have innovation, we have capability, bandwidth, where we could partner and support many of these initiatives that these rural healthcare institutions will be applying for. So there is opportunity for us in the system to support this Rural Texas Strong initiative to really improve healthcare for our rural communities, but it will be in partnership at the local level. And that's one of the reasons why Archie may have a role in this, because of our local relationships with the rural hospitals and clinics. 3 things I want to mention to you all that I think will likely be a focus for all these rural institutions when they're applying for funds. And Archie, as we are providing technical assistance, will recommend these 3 areas of focus as well when looking for initiatives that make sense. First of all, is there a community need? Now, rural communities, there are a lot of needs. What is the greatest need? And what are the metrics within Rural Texas Strong that this community need can focus on and also improve on those metrics? The second component is really feasibility. With many of these rural communities with limited resources, even with funding, is it feasible for them to implement an initiative? And then finally, how can this initiative, this program within Rural Texas Strong be sustainable? We know the Medicaid cuts are continuing beyond the 5 years. How can rural healthcare institutions have programs that are sustained after the period of funding? Now, this may open up a lot of questions for y'all. We have an hour and a half if we go that long, and there will be opportunities for you to ask many questions. But next, I would like to introduce our next speaker, Victoria Grady. As Cassidy mentioned, she is Director of Provider Finance in the Chief Financial Office of the Division of Texas Health and Human Services, HHSC. Tori oversees the development and implementation of reimbursement methodologies and rates for Medicaid and certain non-Medicaid services, supplemental and directed payment programs for hospital services, long-term services and supports, and acute care services. Now, Tori began her career at HHSC in 2014, serving in multiple roles, which she was successful in, and rapidly became Director of Provider Finance in 2018. Prior to joining HHSC, she worked at the Texas Senate Research Center and as Chief of Staff for former State Representative Jim Pitts. And I have to say, I hope Tori and her team get the recognition they deserve. Creating this program, Rural Texas Strong, in a matter of weeks, was a monumental task, and they were up to the challenge. So, Tori, I will leave the stage to you, and you can talk about the 6 initiatives.
And for the kind words, I will say that it was a labor of love, and we were really honored to get to do it. But mainly, we were really felt like we were just kind of a vessel to relay the things that we learned from our rural communities. So we have 6 initiatives that we included, and they are big and they are meaty, and they were really born out of effort that we made to go to our rural communities. So along with John Henderson, who took a leave of absence from Torch to come over and work with us for 2 months, we took in hundreds of public comments. We distilled down what the notice of funding opportunity allowed, and then we built an application. And I would say the most instrumental thing that we did is we spent a week on the road. John traveled more than 2,200 miles in 5 days, and I did 3 of the days. My boss, Trey Wood, our CFO, did 2 of the days, but we visited 5 different rural communities representing East Texas, the Panhandle, West Texas, South Texas, and Central Texas to hear from them. And so our 6 initiatives are make rural Texans healthy again. So this is our nod to MAHA. And really it's about chronic disease management and prevention. There are a lot of different options. There are 8 in total specifically that communities can choose from of required activities, and they range from everything from an after-hours clinic or urgent care to setting up community partnership resources with computers to help people with making choices about Medicare Advantage or Medicaid managed care plan selections and things like that. So really kind of a big spectrum there. Eligible providers for that initiative will include rural hospitals. We started with focusing on rural hospital districts. With the additional funds that we got in our actual award, we've increased the amount of funding that'll be in that initiative, and we'll also open it up to private rural hospitals. We know that in many cases, a rural hospital serves as sort of an anchor for the healthcare community throughout that area. Or throughout the area that they serve. Our second initiative is Rural Texas Patients in the Driver's Seat. So this is really about how to engage Texans in their own healthcare. So whether it's through a patient portal to let them exchange messages with their provider, to be able to access lab results, to be able to really start to engage in their own care more proactively, but also to engage with other consumer-facing technology. So we know that like continuous glucose monitors that can interface and send data directly to the provider without needing to schedule an appointment, or things like a remote dialysis machine that you can use at home while you're sleeping, so you don't have to set up dialysis time that takes you away from your life and your work. There's a lot of different advances. And so this is initiative is going to be really focused on helping to deploy those types of resources directly to consumers and for the providers working with those consumers. That will be eligible for clinically integrated networks, accountable care organizations, or other like similar cooperatives to be able to bid on. The goal with that is to be able to make sure that those organizations are able to leverage their like bulk buying power for their members, as well as to maintain help with the pathway to sustainability at the end of the 5 years. For the third initiative, it is Lone Star Advanced AI and Telehealth. So we heard a lot from providers about they want to be able to build out as much expertise and support in a rural community as they can. However, due to patient volumes, they may not have enough client volume to sustain certain specialty practices. And so being able to leverage remote telehealth technologies so people can be served as close to home as possible was really important. We also know that there's a lot of opportunities with AI. Even in the 8 months since the application was developed, there's been new releases of technology. And one of the solutions we're really interested in is like ambient listening technology. So rather than having to have a scribe or have an individual who, after they're done with their long day of seeing patients, has to do a lot of time charting, to be able to have that technology chart and take notes for them. We think that that's going to help not only with client care, but there's also options to help with back-end processes, with coding, with prior authorization requests, and things like that. Most EMRs are currently offering options to enable that type of AI solution, but it costs money, and it also requires some investment to do the initial configuration. And so especially coupling that with telehealth, so we're using all of the tools in the toolbox that we can. Our next solution is the one that is my personal favorite. It is Next Generation Small Town Doctor and Team. And so this is really workforce development. So second to our MAHA initiative, this is where the most dollars went. And this is really about bringing not only physicians to communities, but all of the allied health professionals that go along with those physicians. We have particular outcome measures there around like EMTs, community health workers, and other professionals that we know are really critical to serving rural communities. One of the things I think is particularly special about this initiative is that you're able to use it in one of 4 ways. You can either use it for creating career pathways for high school students, so helping folks with getting, their CNA, and putting them on that lifelong path towards maybe a career in healthcare or other things like that. Helping with stipends or scholarships for individuals from the community who want to pursue a healthcare degree. So whether it's an associate's degree, a bachelor's degree, or beyond. It does include recruitment and retention funds if you want to attract a early, mid, or late career professional to the area, in order to bring talent that's already been established. And then the last is to set up new residency programs, particularly in partnership with other urban hospitals or academic institutions. And I will say, when we talk about residency, we don't just mean for doctors. We're also interested in like nurse residency programs that we know can really help retain nurse practitioners in the workforce. And so those are kind of the 4 options. I think the other thing that makes this particularly special is that we do require them to build out a mentorship or community support to wrap around these individuals. So we don't just want them to put somebody through school or pay them a bonus to move there, but we really want to make sure that folks are being integrated into the community and into the care of their community, because we think that that is really fundamental to the lifelong retention of those professionals. And I would say that that influence about the mentorship really was something that John brought to the table and emphasized in talking with us from his experience growing up in a rural community. I grew up in Los Angeles, so it's wild, but not in a rural way. Our next initiative is unified care infrastructure and cyber protection. So we love technology, but we know that technology can be as much of a frustration as it can be an ease when systems don't talk to each other. So this initiative is really around bringing all of these systems and tools, whether it's your EMR system, your billing coding system, your patient portals, your HIE connection, and really making things as interoperable as possible. So you have a unified system that eases that user experience. As well as making sure that everything is secure. So all the way from the server, the physical hardware, through to the laptop or the fax machine, into the software systems. As part of this, we're planning to set up a state operational command center model to help with endpoint detection and response, software and monitoring. I've learned a lot about what all that means. But basically, we want to make sure that we keep the data secure and protect Texans with all of this information that will be stored electronically about them. And then also make sure that folks who are users of the systems have the digital literacy to know how to manage all of that information in a secure and appropriate way. And then our last initiative is infrastructure and capital investments. We ran out of time to be able to come up with a cute name for this, but it really is just about making sure that the facilities are up to snuff. Nobody wants to get care in a building that they feel is scuzzy. Practitioners don't want to come and work in a building that they feel like is gross or not looks, professional. And so this includes everything from equipment acquisition to minor remodels. This is a space that is kind of interesting. Usually federal funds are not available for improving your physical plant, but these are. We do have a prohibition on new construction, so you can't build a brand new hospital, but you could do things like renovate a space to be able to bring like a women's imaging center to a community and fix up a place and be able to, bring in the MRI or CT scanner or things like that. You can also, with this money, do some, cosmetic upgrades to help with things, or you can do some more basic things. If you need to improve your plumbing, you need a new roof. There's options there, and we know that it's really hard to deliver good patient care when you have a leak dripping into a bucket next to you. So we are really excited about this opportunity. I will tell you that they're in the course of figuring out where the additional $400 million that we were awarded but hadn't included in our initial budget was going to come from. Our commissioner did identify that she wanted to prioritize $50 million of this additional capital funding specifically for folks who are serving folks with intellectual or developmental disabilities or physical disabilities. So we know that some of the buildings in rural communities are older, and that means that they may not be as accessible for folks with individual disabilities. And so there is a particular prioritization of around $50 million for providers who need to make those types of modifications to their space. And that is it. I will tell you, we are still working through our federal approval process on our budget revisions. Given the magnitude of the dollars we received, it's a process with them, but we've been talking to them about every 2 days for the last couple of months, working through a lot of the details and making sure we're compliant with all the federal limitations. So as soon as we get that approval, we will post it online, and that'll have a lot more detail about exactly what they've approved us to do. I'm happy to turn it to John.
We can open it up Tori, just for any questions for
Yeah.
you. I
Yeah.
will say, everyone, we have, after John presents, another 20 or so slides that go into each of the initiatives, looking at the metrics that HHSC has posted, going over the initial timeline, which may be adjusted, as Tori said. So I suspect if by the end of the presentation, most of your questions will be answered, but feel free at this point to ask Tori any questions. And you can post the questions on chat, or you can just put your name in chat and Cassidy can unmute you.
Yeah, I have the chat up, and right now we don't have questions, but we'll give it a few seconds if you are in the process of dropping your questions to chat. But Victoria, Dr. Sharon Dormeyer says that this is thoughtful work. Your team really did listen.
Thank you.
Okay, I don't see anything else, Dr. Parsi. I would love to take a moment now to introduce our next speaker, John Henderson. John is the president and CEO of the Texas Organization of Rural and Community Hospitals, also known as TORCH. He works for the 156 rural Texas hospitals, primarily in the areas of advocacy and education. Prior to joining TORCH in April of 2018, John served as the CEO at his hometown hospital, Children's Regional Medical Center, for 16 years. During that time, he served as chairman to both the TORCH and Texas Hospital Association boards. So thank you for joining us, John. I will let you take it from here.
Hey, thank you, and good morning, everyone. I don't have a presentation to share. I could not have set the table any better than Dr. Parsi and Tori did this morning, and I don't want to be duplicative. So I'll just give a little bit of perspective on what y'all have already covered, and then I'm happy to answer questions about anything y'all want to talk about. That introductory slide, the only edit is we're at 155 rural hospitals in Texas. I think there was a change related to the hospitals in Bastrop and Smithville, and we haven't updated that introduction. But that's who's eligible from a hospital perspective in the rural transformation funds, along with all kinds of rural providers that are providing services in rural Texas counties. So 70 or 80 FQHCs, 380 or so rural health clinics, EMS services, pharmacies, behavioral health providers, opioid and substance abuse providers. It's not just hospitals, but of course, hospitals are doing a lot of this work in rural communities. I agree with the way Dr. Parsi framed this up. I actually am hopeful about this program, at least over a 5-year time frame. Beyond that, it gets a little cloudier. But rural Texas is disproportionately poor and Medicaid oriented, especially if those communities still deliver babies. But the Medicaid changes in the bill are modest relative to some of our neighboring expansion states like Louisiana, Oklahoma, New Mexico, et cetera. And Texas, thankfully, got more allocation of rural transformation funds, 1.4 billion. Doesn't look as good when you look at it on a per capita basis, and it's hard for me to get my head around billions of dollars, but it's certainly enough money for us to do some things that matter and actually move the needle in these communities that we're trying to serve. Second thing is Dr. Parsi called me a consultant, or I guess I was a subcontractor for a couple of months in the fall, but that's not who I am for the other 52 years of my life. I'm a country boy from the Panhandle of Texas, and I'm a rural hospital guy. Number three, he is right. There were no funds devoted to the university systems or academic institutions in this application, but that's not to say there aren't going to be opportunities for partnership and collaboration. If you read the plan, there was clear intent to get the money to the folks taking care of rural communities, but they will need help and they will engage people as they see fit. As far as what Torch is doing in this effort, we work for those rural hospitals. We want providers to be aware of the program and be ready to participate. As you can imagine, 155 rural hospitals, some of them are all over this. Some of them are system affiliated rurals and kind of waiting on system resources. And some of them are in survival mode and they haven't read it yet. So we want to make sure that everyone knows about it. And to the extent they want to participate, this is voluntary, but we don't see any reason every rural county and provider would want to participate. We want them to have the tools they need to do it effectively and handle the reporting and have a good story to tell at the end of 5 years. We have hired a few people at the Torch offices. We're in Round Rock. We're going to have them one go east and one go west and try to just be a resource to those hospitals primarily, but also the rural health clinics in Texas. There are FQHCs that are eligible, but the FQHC Association is probably a little bit more engaged and structured, whereas the rural health clinics, well, out of the 380 in Texas, about two-thirds of them are provider-based, which means they're attached to a hospital and function as a department of the hospital. Those folks are going to be okay because they're tied to the hospital. But about a third of them, more than 100, are independent rural health clinics, and we want to intentionally find them and make sure that they're aware and participating, even though that's not historically who we serve. We really want to bring everybody along in this work. We may at some point respond to an RFP from HHSC around a couple of initiatives. I make a distinction in my mind between the initiatives. Most of our folks don't need help knowing their workforce needs or their capital equipment needs, but for initiatives 2 and 3, maybe 5 that are a little bit more innovative, we maybe see some value in being able to aggregate and scale and leverage those solutions in a way that no community hospital could do on their own. And so when we have the opportunity to do that, we're going to take a serious look at it. In my time, which is 8 years at Torch, we've really never asked what's in it for us. We try to serve the community and meet their need. This is more dollars than we've ever dealt with, but we hope to hold on to that philosophy and do some things that not only help folks take care of their communities, but do it in a way that we can sustain it even beyond the 5-year federal program. So I'm going to pause there. I'm happy to answer any questions that y'all have or talk about anything we may have missed.
Thanks, John. Let me check the chat and see. I don't see anything in the chat. So just a reminder, if you have questions for John, and I think Victoria is still on, please drop those in the chat. And if not, we can move on to the next portion of the presentation. I don't see anything coming in. So Dr. Parsi, I think we're back to you.
Elda Ramirez, did you have a question? I thought you raised your hand if you want to ask your question.
Yeah, I was looking, as you understand, I was looking at your website's maps of like where you only have 3 ERs, 3 rural ERs. And I was also looking at like what facilities you have. I'm in South Texas and there's like 0. You have no facilities anywhere. I'm in Laredo, Texas.
Well, every rural hospital has an ER. I'm not sure what map you're looking at. It may
It's
be
on your
showing.
website. It's called Map of Rural Emergency Hospital Sites.
Oh, that's not an emergency room. That's a new federal designation that came about, and there are only 4 of those in Texas. But it's not showing an emergency room. It's showing a specifically designated hospital type that's relatively new. And with regard to South Texas, I think it's commonly misunderstood. The Valley is not rural. Y'all aren't urban, but you have enough population at the county level to not be rural. So
Right.
our furthest south rural hospital site is Rio Grande City in Starr County.
Except I'm up from there. I'm in Laredo, so I'm
Yeah.
not a Valley girl. I'm up from there. That's why I was just, because that was my next question, is that the definitions of rural
Mhm.
are, I'm assuming that's coming in the next section, but that's, for us, it's really important to be able to define from where we are
Yes.
to be able to.
Is Laredo Webb County?
Yeah.
Okay, so for purposes of the rural Texas Strong application, we use the Medicaid definition of rural, which is a county population threshold of 68,750. And so that's what I was trying to call out is, and Starr County is close to that threshold, but Webb County, I'm sure, is not rural for the purposes of Medicaid in this program.
Okay. Thank you, Elda. I don't see any other raised hands or chat questions. So Dr. Parsi?
And just to add on to what John said, there are 202 counties in Texas that fit that designation under Rural Texas Strong, the rural population designation. Well, John did a great job in talking about Torch. That I will say every rural hospital is a participant in Torch, and that growth came under John's leadership. So he's done an incredible job. I'm sorry I used the word consultant. I know that might be a dirty word, but John's not just a rural boy. He grew up as the son of a rural doctor. So, and then became the administrator for that same hospital that he was born at. So appreciate both John and Tori's comments. Now we're going to get into some of the weeds of the programs. Now I'm going to add a couple qualifiers. This was using a documentation that HHSC made public that is all tentative. And if Tori's still on, she may be able to speak. They can only speak to what they have publicly reported or have available in the public setting. And we pulled from that to try to describe each of the initiatives. As she mentioned, they're having conversations with CMS. There will be amendments. So some of the things that I'm going to share with you, some of the timelines, the amount of money, et cetera, will likely change. In fact, I'm pretty sure some of them will change. This slide was taken from a HHC document that, again, I believe will be revised. So I wouldn't say this is exactly how things will be, but this will give us some context. For each of these 6 initiatives, there is subaward opportunities for some of them and contracted opportunities. The subaward would be those that are eligible. So for instance, in Initiative 1, they specifically designate hospital districts in rural communities. If there's a hospital district in one of the 202 counties that are considered rural that own and operate a hospital, they would be a subaward recipient. And for the first year, the initial estimates were $250 million in year 1 for the sub-award recipients. Now, for those of you that don't know what a hospital district is, it is an entity, a taxing entity that is created through taxing local funds. It could be a countywide entity. It can be a city with a surrounding area as well. Not every hospital district in Texas has a hospital. There are some hospital districts that are just a hospital district without a hospital. There are some hospital districts that are rural that may have a hospital, but it's not operating. We were in Trinity County recently. They had a hospital that closed. So they may not be eligible for the subaward recipient funds. And then there are some hospital districts that own a hospital that may not be operating the hospital. They may be contracting. For instance, in our community, Burleson County has a hospital district. They own a hospital, but they have a community hospital system that is managing the hospital. So who is exactly eligible for the subaward recipient criteria? HHSC will make clear, but they have used the wording hospital districts that own and operate a hospital as being award recipients. Tori also mentioned for initiatives 1, 4, and I believe for initiative 6, the initial request was $1 billion. CMS gave Texas $1.4 billion. So HHSC looked at the different initiatives and identified where they wanted to add the additional funds. And for initiative 1, in addition to sub-award recipients, there is a set of dollars that will be contracted. And in fact, there was a procurement forecast came out last week from HHSC that said in May, there may be an announcement of the RFA for the contracted recipients, similar for initiatives 4 and 6. A couple things I also want to mention to you all. If you take a look, as Tori had mentioned, Initiative 1 is the largest funded initiative. It is over 30% of the total dollars going to Initiative 1. If you add Initiative 1 and Initiative 4, we're at over 50%. So over half of the dollars are focused on the community health initiatives and the workforce development initiatives. And then if you add Initiative 6, we're at 70%. So initiatives 1, 4, and 6 are the majority of the funding allocations. As we have mentioned already, the goal is to transform rural health. This is a state-led program using the federal funds that will be reevaluated depending upon our state performance, every state's performance every year. There are outcomes that will be monitored, and we'll go into some of the metrics that HHSC has provided in their submission. CMS will look at those metrics as well as other signs of outcomes. So it is an outcome-driven set of programs, and continued funding will depend on that improvement to have the funds continue and be increased potentially. I'm going to talk about initiatives 1, 4, and 6 together, in part because these are funds that have subrecipient awards, and the subrecipients are the rural healthcare institutions. So as we mentioned for Initiative 1, Part 1, that is rural hospital districts. Part 2 then expands into rural hospitals, clinics, EMS, hospital pharmacy or rural pharmacies, public health officials, mental health. So if you have, if you're operating in one of the 202 counties and you have a physical address in one of those 202 counties, for some of the contracted awards, you would be eligible for 1, 4, and 6. Now, this is repetitive because Tori did talk about Initiative 1, but it is focusing on the MAHA type of opportunities to improve the health of the communities. Diabetes is a big focus, and we'll go into the metrics in a second. Cardiovascular disease, respiratory disease, obesity. So programs that are trying to improve the health of the communities. And as Tori also mentioned, they give a wide range of different opportunities for these rural county hospital districts, hospitals, and clinics to apply for this funding. And potentially there could be partnerships with TIMU system entities that have the expertise to support this. This budget, again, is tentative, and I suspect the period and time of funding may be adjusted in the near future. These are the outcome measures for Initiative 1. And if you look, there's a significant focus on diabetes. So one metric is related to the population of dietitians, the number of dietitians that are working in non-metro areas. They want to increase the number of dietitians by 20 statewide that are working in non-metro areas. That's a specific metric. They want to decrease the ER visits by 2.5% for diabetes-related visits. So again, creating an initiative that will decrease ER visits for diabetes patients could be a potential initiative or focus for these rural communities. Obesity, decreasing the prevalence of obesity by 1% statewide in the non-metro population. And then they also mentioned diabetes classes, having an increase by 2.5% in the percentage of adults in these 202 rural counties or a non-metro population that are participating in diabetes education classes. I will stop there to see if there's any questions related to Initiative 1. And Cassidy, you can help me if we do have questions.
Yes, absolutely. I don't see anything in the chat. I don't see any raised hands at this time.
Great. Okay, we'll go on to Initiative 4. And that initiative is the Workforce Development Initiative. Of the 202 counties, every rural county is eligible for funding. And in fact, as long as they apply and have an adequate application, they will receive funds in each of the 202 counties, a rural healthcare institution. There is an RFA that is projected to go out in May of 2026 related to Initiative 4. Again, this budget, I believe, will be adjusted. This was a budget without, I believe, an expectation of an RFA that will go out next month. So the dollars may be adjusted in the near future. HHSC will make this public. In addition, we'll talk about the Rural Texas A&M System Hub that will also be a site for you all to utilize. And also, as previously mentioned, there are a lot of opportunities from pathway programs all the way to residencies and ways of trying to recruit active healthcare providers in a community with a 5-year commitment. So there are a lot of opportunities, and many of our academic institutions can definitely partner with these rural healthcare providers to partner and help with workforce development. These are the outcomes measures for Initiative 4. So there is a specific focus on community health workers to increase non-metro population community health workers across the state by 5%. They want to increase the number of primary care physicians in rural counties by a raw number of 40 greater than the beginning of Rural Texas Strong. There's a focus on EMTs and paramedics by improving by 5% the percentage of EMTs and paramedics in rural communities. And then, as Tori mentioned, the mentorship program and coaching to try to not just recruit healthcare providers, but keep them and reduce burnout. Want to increase the mentoring programs by 5%. Any questions on Initiative 2? Initiative 6 was the infrastructure initiative. Again, this is improvements in current infrastructure, not new construction, but equipment, patient-facing equipment, emergency room services, facility systems, improving even some of the cosmetic components potentially could be applications, rural hospitals, clinics, behavioral health providers, opioid substance use, EMS, pharmacies, and public health offices are all eligible to apply for Initiative 6. I'll next, as a group, talk about Initiatives 2, 3, and 5, where 1, 4, and 6 were initiatives with funding at the local level. 2, 3, and 5 have clinically integrated networks, ACOs, or similar cooperatives, or statewide contracts. So these will not be funded at the local level, specifically with each rural community applying. These will be networks that will be applying. So Torch has a clinically integrated network. TAC, which is the group of FQHCs, the organization for the state, they have a clinically integrated network. I believe there's a statewide pharmacy clinically integrated network. As long as the majority of their participants are rural, they could apply for funding under Initiatives 2 and 3. And Initiative 5, as Tori had mentioned, with infrastructure, there will be contracts that will be administered to support at a statewide level. These are not at local rural institution level of funding. Initiative 2, we're looking at technology and other ways to get patients engaged and have access to their health care to help with improvement in their care. Now, although these are different initiatives, you can see how these initiatives may correlate and cooperate and support each other. So program with Initiative 2, where patients have more access to their healthcare records, could support Initiative 1 with opportunities to improve the health of the communities. So they can sort of support each other, these different initiatives at the local level. Initiative 3, as already mentioned, has both the technology component, not just patient-facing, but areas of operations. We'll go into some of the metrics for Initiative 3 to improve the operations of rural clinics and hospitals, as well as telehealth as a capability to extend healthcare access to patients in rural communities. And here are the, I guess I did not include the metrics for Initiative 3. So some of the metrics are related to automating faxes. So that would be an Initiative 3 technology that is identified as a metric. And there are other type of technology metrics that are identified for Initiative 3. The Initiative 5, as was already discussed, is really about cybersecurity and creating an infrastructure to make sure data is secure for these rural healthcare institutions. Any questions on Initiatives 2, 3, and 5?
Dr. Parsi, we had a couple of comments pertaining to Initiative 4. I think the first comment was no nurse practitioners or PAs, and then the second comment was just an awareness that increasing nurses was not specifically mentioned.
Okay. Well, for these initiatives, Initiative 4 for workforce, increasing your capacity for advanced practitioners, for healthcare extenders, for nurses, those are part of the eligibility. If those weren't specifically identified in the slide, there is eligibility for those types of, it says the and team, the rural doctor and team, and that team was pretty extensive. Now, the metrics did focus on community health workers, EMS support as metrics, but there are applications can include advanced practitioners, nurses, and even other support, other healthcare team members.
Dr. Parsi, that was me that put the question in, and it really was about, I noticed it in the metrics because I knew you had said if they were eligible, it was just metrics.
Right.
Thank you.
The metrics were created by HHSC. Cassidy, are there any other questions?
Just another comment about them not having the specific metrics, but I think you covered that, and that's all.
Okay. Yeah, those were the metrics that were created by HHSC in their application to CMS. I don't know if they would ever amend the metrics. If they would, that would have to be a conversation with CMS. So where do we go from here? There are opportunities for our system. How do we do this in a coordinated way? And how do we make sure that we all are aware of the opportunities within the system? TMU has designated Archie as the center to create a hub for Rural Texas Strong. Talk about why Archie was appropriate for this, but this is really an opportunity to do several things. We will create a hub. It will be, it's a part of our webpage for our website, where we will have information on any changes, any HHSC public information that becomes new, really a resource for understanding what is available and also to help understand what are the rural hospital and clinic priorities when you're trying to create programs or initiatives that can support Rural Texas Strong. Archie has extensive relationships with rural hospitals and clinics. We could be a sounding board to provide guidance on the type of initiatives that rural hospitals and clinics may need and support any of these initiatives and goals. We will create a platform, an electronic platform, where we will share these updates, news, and opportunities. And we want this platform to be a place for you all to submit and be able to report on different opportunities that you have. Let me give you an example. TDEM has a paramedicine program that could be useful for these rural communities. On the platform for the Rural Texas Strong Hub, they will be able to publish their program, contacts, and information regarding that program. And then that way, anyone, because this is publicly available, any rural hospital or clinic can access and learn that information and potentially partner. I know the Dr. Gandhi with the Center of Rural Resilience with Carleton State, along with the College of Medicine and Chris Donaldson have worked on a consortium to create opportunities that would be helpful to support rural hospitals and clinics. Great work. They can continue this work. This would be a site where they could put on this platform for anyone in the state to be able to see what they're doing and potentially reach out to them and discuss with them these opportunities. Not just as a platform to illustrate what can be done, but over the next 5 years, once programs are initiated and partnerships are created, I'll give you an example. Let's say Prairie View decided to work with Hempstead in Waller County on an obesity reduction program. This would also be a site where they could report their partnership and the accomplishments. Legislature at both the state and federal level would love to see the accomplishments that Texas A&M as a system is performing, and this would be a site where it would be all public for them. And then finally, Archie could be an opportunity to connect institutions within our system with the rural hospitals and clinics that we're currently working with. To talk a little bit about our institute, Archie has worked for over 20 years with rural hospitals and clinics throughout Texas. Map on the right is the number of counties and the number of programs each county that Archie is currently participating in. We have a number of quality and safety initiatives. Over a third of the rural hospitals use Archie as their designated medical staff peer review. We do nursing peer review, a number of different quality and safety initiatives. And we have the relationships with these rural hospitals and clinics because of these programs. Here is just a number of different metrics, numbers talking about what Archie has done, most recently working with hospitals and clinics across the state. Because we have this relationship and we work closely with them, that gives us an opportunity to communicate the different system support opportunities within Rural Texas Strong. Melissa Lackey, who is our Director for Technical Assistance, is here on this webinar. I'd like to talk about the team that we create using an AgriLife model. We've created regions within the state. Technical advisors are in each region. They'll meet with a hospital to talk about what type of opportunities they need to improve their operations. And this is all aspect of hospital operations, from strategic planning to marketing communications, looking at their revenue cycle. Are they having a high rate of denials? We bring internal and external consultants free of charge to work with these rural hospitals and clinics to help improve their operations. We worked with over 140 this last year. So most rural hospitals and clinics have had a working relationship with Archie to help on their improvement, and we'll continue to provide technical assistance for them as they implement Rural Texas Strong initiatives. If there is something within our system, technology, a resource, a capability, a program that would be helpful for them, these technical advisors can communicate that. The team also includes workforce coordinators that help with student placement within the health science center system, schools and colleges. As mentioned previously, when thinking about how you can support Rural Texas Strong and these rural communities, these three topics will be part of our technical assistance for rural hospitals and clinics and should be areas of focus to consider the programs you want to do. What is the community need? Where is the need the greatest? And how does that need relate to the metrics created by HHSC? So that could be important in decision-making when rural hospitals and clinics are coming up with their initiatives. Again, the feasibility. With limited bandwidth and capabilities, if a rural hospital or clinic cannot implement, then it won't be successful. Potentially, our partners within the system may provide that extra bandwidth to make it feasible, but as a program, is it feasible to operate in that community? And then finally, the long-term viability. Funding is for 5 years. The decreased Medicaid reimbursement goes on forever. The goal of the Rural Transformation Program is to create initiatives that when the funding ends, they continue to be viable and help support the long-term viability of these hospitals and clinics to prevent their closures. So what's next? Well, hopefully this webinar has helped you understand the different initiatives, the funding opportunities, who is eligible for funding, the timeline, which is currently tentative, and where there is an opportunity for you all to create programs to support these initiatives. The Rural Texas Strong Hub that will be attached in a link with the Archie website is under development. Once it's created, it will be a site where you will be able to get communication on these different initiatives and be able to make public the different programs and initiatives that you want to do. And again, will be an opportunity for us as a system to communicate what we've been successful with. Our team of technical advisors that are traveling throughout the state will be aware of what's on the hub and will be happy to link partnerships when they seem most appropriate. So that ends the presentation. I will open it up to any additional questions that anyone may have.
All right.
Great, you have the floor. I was just about to notice your comment. Go right ahead.
Okay, thank you. I'm Dr. Jackie Plemons. I'm with Texas A&M College of Dentistry in Dallas, Texas. And we did get notified of this great opportunity that we have to improve health of our Texans. And we were looking at different initiatives, even something like on number 3, some teledentistry. We have an oral medicine clinic that I staff here at the college where we see patients with medical problems that manifest in the mouth. We're interested in doing teledentistry with regard to that care. Then also there's opportunities there, but also there's opportunities in encouraging providers from local areas, rural areas, to stay or serve the rural communities. And we serve, our students go out at different rural areas to provide care already throughout the state of Texas. So I was hoping that we could maybe put a veil of dentistry across our discussions, and I'm really interested in working with all of you, and I'm happy to meet all of you on this call. So thank you for asking me to come.
Appreciate your comments, Dr. Plemons. We really feel like there's an opportunity. Dentistry and dental care in rural communities has a huge need across the state, and really appreciate the College of Dentistry's their efforts to expand the support. I know you're working on rural rotations for dental students, and Dr. Liang Hong has been leading some of those initiatives. The opportunities you talked about with telehealth, the Telehealth Initiative 3 is a clinically integrated network application that potentially whoever is applying for that, you all could partner with. But telehealth initiatives could also be supported for Initiative 1 on different types of opportunities to improve the health. That's where you don't have to put everything in one box, because Initiative 1 is improving the health of communities. Telehealth can do that. But then there is funding specifically Initiative 3 for clinically integrated networks, or ACOs, to apply for funding, where all of the participants of that network would then have access to what is being applied for in that funding initiative.
Thank you.
Any other questions?
Cassidy.
Not at this time. Oh, I believe, yes. Olga Rodriguez, would you like to speak?
Yes. 2 questions. I think John is still on. Maybe. I see his name, but hey, John.
I am. I've been listening.
Okay, good. There are Texas A&M has such a deep history of working so closely with rural communities for many, many years across not just the system schools, but A&M and the Health Science Center. And we're not the only ones. There's a lot of communities, that have also helped rural communities. And you were at those public hearings with vendors and a lot of people offering to help, right? And so we're hoping that, at least A&M kind of communicating through Kia cannot overwhelm the communities. But I just wanted to get your thoughts on, um, some recommendations that you have on, how we can all work with Kia to not overwhelm the communities.
Well, you said what I was going to say. We've kind of been run over in a good way. I mean, it's a lot of interest. Billions of dollars get people's attention, not just from your community, but from lots of communities.
Yeah.
When I was at the agency, and I don't know if this is the perfect way to frame it, but what I encouraged Tori and leadership over there as I was working for them was to kind of make a distinction between the folks that have been working on these problems prior to the money showing up
Right.
and those that are new to us. That's not to say some of the new, AI vendors don't have elegant solutions to this, but in my mind, I'm trying to put those into different categories. And I agree, not just Texas A&M, but we've got several university systems in Texas that have been great partners, committed partners for decades. And to me, that counts for something.
Mhm.
But we've got to, there are a lot of decisions to be made in terms of how we structure this stuff.
Yeah. Yeah. Thank you.
Olga, you brought up what I really wanted to also say, and my concern is connecting things we all have with the rural communities and their awareness of it, and a plan to do that. Certainly, the hub is a great idea, but I also think we should be proactive. I was thinking like trying to show people how you can bring resources in higher education to the rural communities, because I think we have some awesome strengths. And even collaborating among the different universities. Everybody gets territorial, but it's not about territory. It's about making a difference in those rural communities and being there for them. So I want to be able to share ideas that could be options for your communities in some way. Sorry, John.
I appreciate you calling that out because I was going to challenge y'all a little bit. You know, Texas is big. And we tend to break it up into regions. And with even good services, we tend to fracture those services. I think there's an opportunity. I was encouraged when I was at the A&M event with the rural practitioners a couple weeks ago in Bernie, and I was on a panel, and some of the A&M folks were sitting with some of the Texas Tech folks, and it hasn't always been that way. But I think there's an opportunity here not to just have a solution, but to have collaboration on a statewide basis around better solutions that aren't necessarily tied to where the patient referral goes. And we haven't done a great job of that historically, in my view. You can have a different opinion about that, but I see that as an opportunity to do something for everyone in Texas.
It's definitely an opportunity. And as you said, it's a big state, John. But in rural communities, we need all the resources. We need all the help in the rural communities. And if there's a way to do it in a coordinated fashion that would make it more successful, then we should do that.
Just a follow-up question, if that's okay, Cassidy.
Sure.
Absolutely.
And I think this is a Dr. Parsi and John combo question. And so, John, I bet it was quite the experience looking at everything from agency land versus, over here, it's a completely different world, right? And having worked at Health and Human Services for 20 years, it's a totally different experience being there. My question to you is, the way that some of these projects are usually crafted based on the metrics, meaning whatever the outcomes that they're going to measure and see if you're successful or not, then are you suddenly now going to get 100 community health worker projects because that's the metric, right? And then as Dr. Dormeyer said, then you're not even going to get as many nursing projects. Like how do you think that we can manage really good, legitimate, shovel-ready projects ready to go and help the community with the navigation of going to the metrics, right? Like how do you manage that? Because if I was developing a project, I would see what the metrics were and develop something specifically on that metric, even though, right, I had other projects that were going to help community health, disease management overall, or other workforce projects as well. So how do you recommend that as we kind of brainstorm on those great ideas that A&M has, where we've been a known partner for years and years in these rural communities? How do we balance it with what the metrics are saying that they're going to be measured on?
What,
Dr.
what if,
Parsi, Dr.
what if I take a crack at that and then Dr. Parsi, you fill gaps? Is that okay? I had a good experience at HHSC. It was interesting. It was definitely different than being in a rural hospital environment or even an association. But they're good people and they're working hard, a lot more process and rural oriented than I'm, accustomed to, but that's the way it is, and that's what we have to do. If I were working on initiatives, I would try to do as much of that community work around chronic disease as you can possibly do and organize it at scale, knowing that you have to hit the marks on outcomes. If you don't want federal recoupments, and actually, what we want is to, in subsequent years, get other states money who missed the targets. So we did everything with an eye towards achievable with some local control. We aren't trying to stand up thousands of community health workers. We know that there's a disparity in the ratio of population to community health worker that already exist in data sets at DSHS between urban and rural. So we've got to move that needle and improve it enough to keep our money. But that's not, I think you have to think about the outcomes, but then you build your projects more broadly.
Yeah, but I'm not sure there's much to add, John. Now, HHSC may provide further guidance because some of the funds are subawards. So hospital district is eligible to get that money. So they may provide some parameters as to what you can use that money for. So we'll see if HHSC provides further guidance. But luckily with Initiative 1, diabetes, obesity, we know most rural communities that those are significant challenges and needs. And they gave a list of a number of different types of community-related initiatives that would fulfill it. So I think it's pretty broad, but I would not be surprised if HHSC provides a little bit further guidance once, again, there's a subaward amount, and then there's also the contracted competitive amount of dollars that HHSC may provide further guidance on.
Any additional questions? There's nothing in the chat, but we still have.
Hi.
Yes.
Hi. My name is Kat Hickle, and I'm the program manager for Golden Crescent Moms. We're like a new program that started about 2.5 years ago. I'm not anywhere near you guys. Well, I'm actually located down in Victoria, Texas. We are like we're rural community health workers, so we actually have a program that helps the rural communities. However, obviously we're in Victoria, and so we're located in like a non-rural determination ground, right? So I guess my question is, we already have a program that's established, and we have relationships with like Cuero Hospital, which I learned is a rural hospital. And the relationship that we have is that we get like our top referral source is from them. But also, I'd like to note like Child Protective Services, is also one of our highest referrals, along with H DSHS also refers to us too, that are among the areas. So my question is, since it's already an established program, we are approaching the end of our program. I am interested in sustainability, but also, like you guys said, we're here to help, right? So we're here to help the most people, and the collaboration that you were, speaking of, we have a really good relationship with the Telehealth Institute at Texas A&M that provides the free counseling. So we're community health workers and we're helping them navigate those resources, right? We're connecting them in the L&D, all these mothers postpartum up to a year and throughout their pregnancy. We're helping that, maternal health initiative as well, right? So I guess it's a loaded situation, right? But my question is there anything that you can think of off the top of your head on who we can connect with? Like what can we I just wanted to bring that.
Yeah, and I can take a stab at that. So you already have a relationship with Cuero, which I believe is one of the that their county is eligible. They may own and operate a hospital, have a hospital district. I'd have to look at that for sure. I think there's a good chance they do. John could correct me if I'm wrong. So you have that partnership with them. They will probably apply for funding. And whatever initiative, let's say initiative 1, they want to improve the health of their diabetics. Potentially, you all could then partner with them, your community health workers, to provide education. So you would be a partner with Cuero. They would apply for the funds, and then they would have you be able to support them in their initiatives. Does that make sense?
Yes. Yes, it does. We're also under the opioid response program. So we have that knowledge as well. Do you see that as a potential like
Yes,
opportunity?
yes, an opportunity. Those would be eligible, not in Victoria County, but in the rural counties around you. So I would
Yes.
engage in those conversations. I think all those counties around you have a hospital, but if not, then maybe the county judge. And the only other
Okay.
call out I would mention is there's pretty specific language in this around supplanting or replacing funds. So, and I think that's common in grant programs, but you got to be careful about existing programs versus new programs and making a pretty clear distinction there with what you're doing.
Pat, once we have the platform, the electronic platform for the hub, we would really love for you all to describe your capabilities, resources, your contacts, so you can be on that hub. And then people that you reach out to, they can know about it, but then other individuals, institutions can identify you as a resource.
Absolutely.
Okay, who's next?
Dr. Dormeyer, did you have another comment? Okay, I can't hear. Her hand is raised, but it may be from earlier. Can anyone hear Dr. Dormeyer? Okay, I think you're Dr. Dormeyer. I think you're talking, but we don't hear you. Still can't hear you. I'm sorry.
You can put a question in the chat if you have a question, Dr. Dormeyer.
Yeah. Okay, I think she's working on that. Anyone else? Okay, there are no other questions in the chat. Oh, no, okay. Thank you, John.
How about now?
Yes, now we hear you.
Sorry. I wanted to speak with Kat because I'm actually the co-PI on that grant, and it was an opioid abatement based project, and that funding for you, Dr. Henderson, ends the funding ends in the fall in September. And if I could tell you how much of an impact these people are making, you would be blown away. And I keep trying to share their story because it's a model that I really believe could work around the state. Because those community health workers, the reason they're so effective is they are from that area. They know the women, they know the environment. And it's cost effective because it's less expensive to have the community health workers than, nurses, nurse practitioners providing care. They are saving lives, and I mean that literally. And so that was one of the things I was speaking about is how do we share how important this is and how do we share this impact with others and find a way to make it spread because they are in Moore County. Victoria is just where they're living, but they can't actually serve Victoria. It's the surrounding areas that they're serving. So
Another great example of how the hub could be useful. Our workforce coordinators and technical advisors are meeting with these rural hospitals regularly. They will look at the website, take a look at all of the hub opportunities, and be able to communicate that as well if the hospital or clinic that they're working with identifies that as. So great example, and I think this is why we have this opportunity. I will say it's 5 years. I know people are chomping at the bit to start things. Over the 5 years, there may be hospitals and clinics that don't have a need or opportunity now, but they may a year from now or 2 years from now. So having this hub, having the regular communication, I think will have dividends throughout this rural transformation program and potentially additional funding if the federal government decides to do after that 5 years. So creating this foundation, this groundwork will, I think, lead to opportunities. I think, Cassidy, I believe we are at the end and we're within our hour and a half. So thank you all for participating. Our institute, again, is available to answer questions. We will communicate through this email group of everybody that registered about the hub, when the platform will be up and running, and really think that there is tremendous opportunity for us to make a significant impact and difference in rural communities. And I think, as Olga had mentioned, we have been doing this for years. Now there's an opportunity unique to even expand upon that. So thank you all again. And we will make the slides available to everybody that attended.
Thank you, Dr. Parsi.
All right. Take care.
Mhm.